In recent years, an unlikely hero has emerged in the decades-old medical effort to combat preeclampsia and preterm birth, and that's aspirin. This simple over-the-counter painkiller has been shown to reduce risk of preterm birth and preeclampsia. But despite its efficacy in some pregnant populations, others haven't been so lucky. For some high-risk women, aspirin just didn't seem to work as doctors hoped. So naturally, curious scientists started wondering why. One of those curious scientists is Dr. Rupsa Boelig, a Philadelphia based maternal fetal medicine specialist and a recipient of a 2025 March of Dimes Discovery Research Grant. She had previously received funding by the National Institutes of Health and March of Dimes for a study which found that a normally recommended dose of aspirin, 81 milligrams daily, did not have the same effect in all pregnant patients. Specifically, she found patients with higher BMI or diabetes had a reduced response to this recommended aspirin dose. Her current 2025 March of Dimes research grant will support a study testing how a higher dose of aspirin is absorbed and metabolized in high-risk pregnant women, how it affects platelet function in blood, and ultimately, if women with diabetes or a higher BMI may benefit from this higher dose. Dr. Boelig hypothesizes that in the case of aspirin dosing for high-risk pregnant women, more may be better. And she's here today to tell us why. This episode is about aspirin dosing for high-risk pregnant women. Stay with us. Dr. Rupsa Boelig is an associate professor of obstetrics and gynecology in the Division of Maternal Fetal Medicine and the director of research for the Department of Obstetrics and Gynecology at Philadelphia's Thomas Jefferson University. She's also a 2025 March of Dimes Discovery Research Grant winner. These grants are part of March of Dimes' Thematic Research Awards program, and they're given annually. They support innovative approaches to improve maternal and infant health outcomes through new diagnostics, interventions, and therapeutics. Dr. Boelig joins me today from Philadelphia. Rupsa, welcome to the show.
Thank you for having me. It's a pleasure to be here. And, although this is based on the 2025 grant award that I received, I just have to say that I've actually been supported by March of Dimes since 2018, and which started from a community grant relating to screening for high risk factors for aspirin and improving our use of aspirin in pregnancy. And so it's really a pleasure for me to be here and to talk to you and to give back to the March of Dimes community.
Absolutely. We're glad to have you here, and we're happy to have supported you for so long and look forward to continuing to do so. Let's talk briefly about one of the most interesting questions related to this work, and this was a surprise to me. And this is the question of why aspirin for the prevention or reduction of preeclampsia and preterm birth. And the answer is we don't really know, right? So why is aspirin chosen? What does it do in the body? How is it actually, an effective medicine?
Yeah, so you're right. Actually, aspirin has been long studied. This isn't new for its benefit in preventing preeclampsia and preterm birth. And our understanding is that the early development of the placenta and the blood vessels of the placenta are critical to the health of a growing pregnancy. The placenta is what nourishes the pregnancy. And if those blood vessels start off not healthy, not well developed, then the placenta has increasing difficulty supporting a healthy pregnancy as it continues to grow. And this stress on the placenta leads to complications like preeclampsia or hypertensive disorders of pregnancy, preterm birth, fetal growth restriction, even spontaneous preterm labor. And so that's sort of central to why aspirin has been studied and our hypothesis for why we think that it actually works to help prevent these complications, that it's preventing these tiny clots that are in the placenta that may be preventing that healthy development of the placental blood vessels.
Okay, so that aspirin is contributing to the healthy development of the blood vessels. That's what you said?
Yeah, that's the hypothesis.
The hypothesis, yeah. So you said it has been studied for a long time. It's not new, and yet we're still using the word hypothesis. What is the like? What's the cog in the wheel here of the research? Why don't we know yet, or why are we not more confident to say this is how aspirin helps the placenta be a more kind of healthy organ in the early pregnancy?
That is a great question. I think there's three sort of main reasons for it. The first and the biggest reason is that despite the long history of knowing, that preeclampsia and preterm birth are these major complications in pregnancy, we're still early in our understanding of the exact disease processes that are leading to these outcomes. There's multiple interrelated systems from early in pregnancy that appear to all contribute to the ultimate development of preeclampsia or preterm birth later in pregnancy. And we're still sort of understanding what all those pathways are. And so when you don't know exactly why a disease is happening, it then becomes a little bit trickier to prevent or treat that condition. The
Okay.
second limitation that we've had is that aspirin has multiple effects, actually. It's not just a blood thinning medication. So one of the main things that we often think about aspirin is that it's a type of blood thinner. What it does is it blocks platelet activities. Platelets are these tiny little things in your blood that clot, and that's what they're supposed to do. But sometimes they do it in a way that's not healthy. And aspirin can help reduce those tiny blood clots that we hypothesize are interfering with placental development. But aspirin's also anti-inflammatory. It has these anti-inflammatory effects as well, and we know that inflammatory pathways also contribute to preeclampsia and preterm birth. And so we don't know, is it which pathway that aspirin's working in? Is it one or the other or both together that is related to its effect that we see in reducing the risk of preeclampsia and preterm birth? And so just our lack of understanding, first, of the disease process itself, and then second, of what exactly aspirin is doing to prevent that disease process. Those are the reasons there's still so many questions in the air about what aspirin is doing to prevent preeclampsia and preterm birth and how we might be able to use it better. And the final gap that we have in our knowledge that's preventing our optimal use of aspirin is that for a long time we've been using aspirin in pregnancy the same way that we've been using it in non-pregnant adults. That low dose aspirin that's recommended, 81 milligrams, that's what's commonly used. If you have someone who's not pregnant, they might be taking it because of cardiovascular disease risk prevention. But in fact, we know that aspirin in pregnancy, there's changes in pregnancy that change how aspirin is absorbed and how well it works. And it's different than in a non-pregnant adult. And so I think now more and more people are realizing and looking at, well, what is it about pregnancy that's changing how aspirin might work? And how should that then affect how we dose aspirin in pregnancy? There still remains debate about what dose of aspirin should be recommended. And, the dose that we use in the United States is not the same dose that's used internationally. And even within the United States, although the United States Preventative Service Task Force recommends 81 milligrams, if you look sort of practice-wise, there is a range of doses that's used. And the reason for this is there are, in our, the recommendations to use aspirin for prevention of preeclampsia, that was based on a large number of clinical trials, not just one clinical trial. And the variety of clinical trials used different inclusion criteria, meaning the patients they considered at risk were different. They had different criteria for what was considered a risk factor to be included in the trial. The dose was different across studies, from 60 milligrams to 150 milligrams of aspirin. The gestational age range when it was started varied across studies. And so the ultimate, recommendations that exist now are based on combining that data together and kind of coming up with our best estimate of what dose should be used and when it should be started. But even when you combine these data, different researchers have come to different conclusions about which dose is best, whether they're equivalent across that low dose range, or whether you do actually see a greater degree of benefit with higher doses. And again, I want to emphasize it. When I say higher doses, that's still within the category of low dose aspirin. And so we're not talking about doses of like 300, 325 milligrams. We're talking about still in that low dose range.
Okay, understood. So is it possible then, Rupsha, that a woman with a prior preeclamptic pregnancy who is pregnant again, considered high risk, in one state of the country will get a different dosage and a different start time of that low dose aspirin, like a gestational week, than another woman in a different state with the same kind of history? Is that possible today?
Yeah, and I wouldn't break it up by state. It's not that states have come up with
Okay,
their
just
own
different practices,
guidelines. I
even
think it's
different
practice
OBs.
based. In
Okay.
general, I would say everyone agrees that the aspirin should be started prior to 16 weeks. And
Okay.
that's a national recommendation. That's very well agreed upon. How
Okay.
early you should start it, whether it should be before 10 weeks or 10 to 12 weeks can vary. And then again, although the national guideline is 81 milligrams, if you go to different practices, again, based on the data that's available, your doctor may say, look, I've looked at the data and I think that you should be on a higher dose. And, here at Jefferson, there are patients that we, based on their risk factors, we do recommend a 162 milligrams rather than 81 milligrams.
Okay. And the 162 milligram is the key number in your new study, right?
That's correct.
Okay. Okay. And just to go back to the different risk profiles of women. So, a woman with diabetes versus a woman with high BMI could be getting different doses, different practices. There's no clarity. And what you want to do is shed some light on kind of potentially a universal dose for these women with high BMI and diabetes. Is that right?
Yeah, I mean, I would say what I'm looking at more is how we can better dose it, whether it's a universal
Better
dose,
dosing.
whether it's individualized dosing based on the combination of factors that one person has, whether you have BMI plus XYZ or you have diabetes and your weight is X, then you should get this dose. So what the exact answer is, I don't know. That's why we're doing this work, to see what are the individual factors that are impacting how aspirin works in pregnancy. And, is there a dose adjustment we can make so that despite your individual factors, everyone has the same end effect?
So the big question, Rupsha, is why is it that women who have higher BMI or women that have diabetes before getting pregnant would not benefit from aspirin? What's happening with their blood or blood volume that is different from women that don't have those conditions that prevents aspirin from working as it should?
That's a great question. And a lot of my hypotheses really came from work in non pregnant adults, which also identified that with higher BMI, with pregestational diabetes, and other conditions, there in non pregnant adults, again, it was noted that there is this decreased effect of aspirin. In our prior work, so I looked at it in pregnancy. And like I said, one of the reasons we're still questioning what is the right dose of aspirin in pregnancy is that there's been limited work until more recently about how pregnancy changes how aspirin is absorbed in the body. So from prior work, not my own, but other researchers, they found that if you give a non-pregnant adult and a pregnant adult the same dose of aspirin, those levels of aspirin in the blood are lower. So if you're pregnant, the levels of aspirin that end up in your blood with the same dose is not the same as if you were not pregnant. And that can be related to that increased blood volume that that we see in pregnancy. So it kind of dilutes the effect, it dilutes that absorption of aspirin. In our work, in our prior work, we had another March of Dimes award that was previously awarded and completed. We found that at an 81 milligram dose of aspirin, women with a BMI over 30, that those levels of aspirin in the blood that we measured after taking that dose of aspirin were lower. So again, same dose in pregnancy, and now with an added effect of higher BMI, you're having a lower dose of aspirin. We then looked at a larger population of pregnant women and found that when everyone was getting that same 81 milligram dose of aspirin, we looked at a variety of different risk factors. We looked at hypertension, age, BMI, diabetes, kidney function. But the main effects that we found were that if you had a higher BMI, and we looked again at the BMI greater than or equal to 30 or not, and if you had pregestational diabetes, when we looked at platelet function, what aspirin should do is inhibit platelet function. It should make those platelets not work as well. And we found that women with higher BMI and pregestational diabetes did not have that same reduction in platelet function as we see in patients without those risk factors. So those are two specific factors I found that seem to be affecting how aspirin is working in pregnancy. And so that's why I wanted to explore those factors specifically.
And when you say reduced platelet function, that means reduced blood clotting. Is that synonymous?
Yes, that would be, that's one way to look at it. And that's actually how we measure it. There's a specific test that we do that is actually measuring like how fast your blood clots a small hole. And that tells us how fast those platelets are working.
Okay, so if the blood is clotting quickly, we know that the aspirin is not working as it should.
Exactly.
Okay.
So when you take aspirin, you should have sort of a longer time that it takes the blood to clot that hole, because the aspirin is inhibiting those platelets. And so we found that time is not the same across all patients in pregnancy. And like I said, specifically, we found what I found most interesting was that higher BMI and pregestational diabetes, you have this significant difference in platelet effect of aspirin.
Yeah. And Rupsa, is this work that you just talked about now that you found that, is this how we know that aspirin, the current dose of aspirin does not work as well for high risk women? Or are there other reasons we know this? Like, have there been studies about, outcome based studies about whether these women still get more preeclamp, end up, whether women with higher BMI or diabetes go on to have higher rates of preeclampsia and preterm birth than women who have than women who are given the low dose aspirin that do not have diabetes or high BMI? Or is it just your work that has shed light on this problem?
So that's a great question. So the other studies have not identified sort of individual factors that are impacting the effect of aspirin. But that being said, we know that even among our high risk patients who are taking aspirin, there remains a high rate of preeclampsia and preterm birth. And so it's not that we're giving these high risk patients aspirin and now they're kind of back to being a low risk person. They remain at increased risk. And that's what has driven some of my initial research inquiries is like, why are we still seeing this? We're giving the aspirin. Why is this still happening? And there are currently clinical trials looking at higher doses of aspirin, either in everyone or in specific populations to see, is there a clinical effect of increasing the dose of aspirin?
Okay, very good. And we don't know the outcome of those yet.
No, those are all ongoing as well.
Yeah, so then we should clarify then that you are not, that the study that you are conducting that involves real women, real pregnant women at high risk, is not measuring whether these women that are given a higher dose of 162 milligrams daily go on to have higher rates of preeclampsia or preterm birth than women who are given, that don't have BMI or diabetes, that are not high risk. But that's not what you're looking at. You're not looking at outcome based. These other studies are doing that. You're actually looking at the I guess the speed and rate of the blood clotting itself in their blood. Is that right?
Yeah, and so we're doing a smaller study. So there's not enough patients to be able to see enough to see a difference in rates of these clinical outcomes, although we're measuring them. But we're doing sort of a smaller, more granular study to better understand how aspirin is working in pregnancy and to provide a basis by which you can come up with what dose someone should get. I think part of what drives me is that, you can do large clinical trials where everyone gets one dose or another dose, but I want to know, how are you coming up with that dose number to begin with? Where is that coming from? We know that we cannot just take data, again, like I said, from non-pregnant adults, because pregnancy is changing how aspirin is working. And so while there are these larger clinical trials, I hope my work will help answer the question of more granularly, is there can we use these measurements to say like, okay, this is the end goal of what we should be achieving, and you should dose until you get to that end goal. Or based on these combination of factors, we can calculate what the dose should be based on, what your individual characteristics are. And so I think it can better inform clinical care and potentially even future clinical trials rather than kind of just picking doses out of thin air.
Yeah, absolutely. You're asking the question why, and you're trying to uncover the pathway and all the very important details. So, hats off to you. That's fantastic. So then, tell me about the trial. Will you tell me when is it happening? How many women are being enrolled? Are they all from Jefferson? Are some of these women your patients? What will you do? Will you take their blood before their daily start at 16 weeks, then you'll take it after, you'll see how the blood clotting is happening? Just give me an overview of the entire study, if you don't mind.
Sure. So actually, following the last study we did with support of March of Dimes and the NICHD with grants from both those organizations, we, like I said, identified that there are patients that are not having the same effect of aspirin as far as platelet inhibition. And in combination with other researchers and other evidence looking sort of back at all, combining all the data, our group had come to the conclusion that, there are actually pregnant patients that should be on that 162 milligrams of aspirin daily. And so our practice actually changed. And this current study is looking at patients who are recommended 162 milligrams of aspirin. So regardless if they were participating in our study or not, that's what that's what they would be recommended to take. And we're looking at, so, we have all this data from women who took 81 milligrams daily. We had blood measurements looking at the levels of aspirin in their blood over a 6-hour period after taking that dose of aspirin. We have blood measurements through pregnancy, looking at how platelet function changed through the pregnancy from the first through the third trimester after starting aspirin. And so we're doing the same type of study, but now we're looking at pregnant patients who are taking 162 milligrams so that we can compare a number of different markers to see how is this higher dose affecting these markers that we looked at in pregnancy. Does that help explain what we're seeing? Does that help support that, okay, maybe this higher dose is what's needed? So let me give you an example. If we give a higher dose of aspirin, but the platelet function is the same, meaning, we've given this higher dose, but we're still seeing that same time it takes for the blood to clot, well then, maybe that higher dose isn't helpful. And then why are we exposing a patient to potentially more side effects if it's not giving us the effect that we want to see? So that's the reason for looking at this, because you can't just assume that a higher dose is leading to double the effect. It's not a one-to-one relationship like that. And there can be side effects. And so we want to be mindful about what we're doing.
Yep, absolutely. Talk to me a little bit about those side effects. What's the negative of taking aspirin daily? Starting in early pregnancy.
Side effects of aspirin, most common, I'll say honestly, most people don't have many side effects with aspirin. Some side effects are GI side effects. So some people can have reflux or gastritis. That would be the most common side effect. Aspirin is a blood thinner. There can always be a risk of bleeding, although in many clinical trials, there hasn't been any increased risk of significant bleeding with aspirin in high-risk pregnancies.
Okay, wonderful. What about the ductus arteriosus? Aspirin is a prostaglandin synthesis inhibitor, and that may negatively impact the ductus arteriosus. And this difficult to pronounce term is an important part of the baby's body for blood delivery from mom to baby. I'm guessing through the placenta. So could a higher aspirin dose in these high-risk women in your trial or going forward trigger this negative effect and cause harm to the baby?
So the ductus arteriosus is, just to be clear, it's not actually part of the placenta. That's part of the fetal circulation. It's one of the blood vessels in the fetus's body, and it is important. Again, low dose aspirin, which as I mentioned, we're still sort of in the category of low dose aspirin, has not been demonstrated to have an adverse effect on the ductus arteriosus, and that would be a rare outcome that you really need much larger studies to evaluate, and the combination of clinical trials to date on aspirin have not found that to be an effective low dose aspirin.
Since you said it's not universally given, this is given to high risk women, but 81 milligram works for some high risk women with some conditions that make them high risk, right? But the women who have high BMI and diabetes, it's not working for them, right? So can you tell me
So I just
what
want to
high
back up.
risk?
I don't want to say that it's
Yeah,
not working for them, because again,
as
this is
well,
not a clinical,
right?
like a phase 3
Right. So
trial.
yeah,
It's
yeah, yeah.
just we found like they're still
Where's,
having an effect. Their platelets are still being inhibited. It's just not to as great a degree as if you did not
yes,
have diabetes.
yes, yes. But so what conditions are okay for that 81 milligram? What high risk women actually are fine with an 81 milligram dose?
In our prior study, looking at the 81 milligram of
Yes.
aspirin, like I said, we looked at a variety of factors, and we didn't see, for example, a difference in platelet inhibition with chronic hypertension, which is another common reason to be recommended aspirin.
Okay.
Just simply having a history of prior preeclampsia, there wasn't a difference in platelet inhibition specifically
Okay. Okay.
with that
Okay.
81 milligrams of aspirin.
Okay.
Age actually was associated with a difference in effect, but not as much a degree as we saw with BMI or with pregestational diabetes.
Okay. Okay.
And then I also want to highlight that, like I said, different studies have used different definitions of risk factors, different like previously completed clinical trials that showed aspirin was effective, used higher doses in women with these high risk factors as well. And so it's a combination of, as far as what we do in our practice, recommending the 162 milligrams for patients with any high risk factors. It's based on really a clinical trial data that showed with a higher dose that showed that it was effective in reducing preeclampsia and preterm birth. And so, like I said, my work that we're talking about now is not looking at that, whether
Yes.
there's a difference in that long-term clinical
Yeah.
effect, but specifically better understanding how aspirin is working, what are the different factors that impact how aspirin works in pregnancy, so we can be smarter about how we're using it.
Yeah, of course. And based on what we know about reduction of preeclampsia and preterm birth with that 81 milligram for women that it does work for better than others, what kind of reduction are we talking? How magic is this pill? Or
So
can it be?
we generally say 20 to 30% reduction.
So significant, very
yeah,
significant.
it's a significant reduction. Although I'll say, although that's true, and depending on which outcome you look at, the exact percent is different. Like I said, still these patients remain at high risk, and even with aspirin, they remain high risk patients and should be vigilant for those outcomes of preeclampsia and preterm birth. And I think it just shows how much room we have to grow as far as the tools that we're using to prevent these potentially devastating outcomes.
Yeah, absolutely. And so, Rupsha, let's talk a little bit more about the trial. I have one more question for you about the trial. So, we're talking about 162 milligrams daily for this one. Where are you right now? Are you enrolling patients? Is this retrospective, or is the data already there and you just have to compile it and analyze it? And when can we see the results? When can I have you back on the show to talk about what you found?
So we're still enrolling. We're over 50%, but we're following patients. We're doing these studies in the first trimester and in the third trimester because, as you go farther along in your pregnancy, there's obviously changes in blood volume. There's potentially changes in platelet function itself. And so I really want to see it follow these patients through the end of pregnancy to see how aspirin is working, for that entirety of the pregnancy that you're recommended to take it. And so we won't really have answers until the next year. The patients that are enrolled need to get through the third trimester and deliver before we can analyze that work. So hopefully, this time next year, I'll be able to tell you more.
Oh, good. Okay, that's pretty soon. Wonderful. And so, if the thing that you tell me in 1 year is that these women did respond better to this higher dose of 162 milligrams and side effects were not, severe, what is next? Will there be a clinical trial or a validation study? Can we expect to see recommendation changes, or is this going to be still up to every doctor at every practice? What happens next if the hypothesis pans out?
Sure. So I think a few things. One is I'm actually doing another clinical trial looking at with 162 milligram dosing if it's better to take that together. So it's 281 milligram pills together in the morning, or one pill in the morning, one pill in the evening, and splitting that dose up. So that's an
Interesting.
ongoing trial as well. As I mentioned, there's ongoing large clinical trials looking at comparing 81 milligrams to 162
Mm-hmm.
milligrams. And so I think our findings, when we see those results and we can parse that out into, okay, was there a difference based on individual characteristics? I'm hoping that our work can inform any differences that might be seen in a larger clinical trial. And we're also looking at other markers. When we've been talking, we've been focusing on specifically a measure of platelet activity or platelet inhibition. But I'm also looking at other markers that mark the effect of aspirin to see, is there another um, marker that we can look at to say, well, this is what aspirin is doing, this is how it's changing, and that is a good way for us to say, yes, aspirin is working or it's not. Because, like I said, although we know in general what aspirin does, right now we don't really have a goal for, like, okay, well, you should take as much aspirin as it needs for us to see X, Y, or Z on a test result. We don't have that. That's why everyone's getting the same dose right now. So I think ultimately, if we could have a test to say, like, okay, we're giving you this dose of aspirin, this is the effect we want to see, and you have or have not achieved that effect. And if you haven't, then maybe that's someone that needs a higher dose. I think that those are kind of the next steps that I'm looking at.
Yeah, yeah, no, totally. So two related questions there. One of those markers is that you're looking at is microRNA, right? So tell me a little bit about what MI you can name it if you want. What miRNA mRNA you're looking at, and why do we need this other marker? I mean, obviously, for scientists, the more markers, the better. I understand, but isn't there a test already? I mean, you're testing these women's blood to see how it's clotting. Why is that not enough? And tell me about the mRNA that you're zeroing in on here.
Yeah, so we're looking at microRNAs, which are non-coding factors, the little RNAs that affect how genes are expressed. And
Yeah.
so they can sort of affect what pathways are on and off. The reason it's important to look at these other markers, and I'm looking at specific microRNAs. These are the ones that we're looking at have been implicated in preeclampsia and preterm birth, and so that's why we selected those to look at. Other researchers are looking at other markers like inflammatory markers to see how those change with aspirin. And it's all to answer this question of what is the effect of aspirin we're looking for that's related to the outcome of preeclampsia and preterm birth. I was really excited by our prior work to see that the degree of platelet inhibition was different in patients who ultimately had a preterm birth versus didn't. So patients who ultimately had a preterm birth in our prior study, their levels of platelet inhibition in the third trimester were lower compared to patients who had a term delivery. So for me, that's telling me, okay, maybe this is a marker for aspirin's effect and the goal effect that we wanted to have. And similarly, there's some microRNAs that we found that were different in women who had a preterm birth versus a term birth. And so again, it's not ready for prime time, but it's just a hint saying, like, look here, this might be helpful in telling us that aspirin is doing what it wants before we, have to wait until someone has a preterm birth, and then we're too late, right? So we want to know before someone gets there that what we're doing isn't working and we need to be doing something else.
But can't you take that blood to see what's happening to the platelet turnover throughout pregnancy so that you don't have to wait till birth? Or
Yes,
is it just
exactly.
like the
So
more
that's why we're
the more
looking
the
at these
better?
markers earlier in
Yeah.
pregnancy, both in the second and the third trimester, to see if there's, if they change with aspirin, showing us that aspirin is doing something to these markers, and then B, if that helps us tell us whether that's actually the therapeutic effect of aspirin that we're looking for. If there's a change in a marker, but it doesn't relate to a pregnancy outcome, then that's maybe not as helpful, right? What we want to know is, what is aspirin doing How is it changing things in the body that is ultimately going to help us prevent a preterm birth? And how can we measure that to make sure that someone's getting to that level?
Yeah. And so the reason that the platelet turnover marker is not good enough, what is that reason? Or like why are we looking for more markers? Just because it's that's what you do, and it's important because the more that you know, the more you can understand? Or is that not a good enough marker, and
Well,
microRNA
it's
might be a
that
better
it
one?
needs to be validated in larger studies, and I think
Sure.
rather than just looking at only one thing at a time, since we're doing this work, we're taking
Let's uncover
these
everything we can.
pregnant patients are
Yeah.
very graciously giving us blood samples through gestation, that it really behooves us to be thorough in our
Sure.
investigation. And like I said, aspirin has multiple pathways that it works. And so I think it's
Mm.
interesting to
Mm-hmm.
see what are those other potential pathways
Yeah.
that might be leading to this, beneficial effect that we're looking for.
Yeah, absolutely. Well, that's fascinating. I want to end on a personal note. Rupsha, you've been in the field of preterm birth since 2015 in the research field as a scientist, 2015. So happy 10 years to you. It's 2025. And you started working with us just 3 years after that, so that's great. We've got a long relationship too. And you've been working on aspirin dosing for preterm birth and preeclampsia since 2018, right? So that was the beginning of our relationship. So for you, why this space of preeclampsia, preterm birth? Why this research? Is there a personal connection for you?
I think, we like talk about these things and we say, this is a pregnancy complication. But when it happens to you, it's not, a complication. It's your whole life. It's your baby's life. It's your future. It's the future that you imagined and the future that you're now faced with. And it changes you. And I think it's easy to think about these things as numbers, and we're looking for that number to go down or a number to go up. But um, I think for me, I know it's more than a number. And every time I have to tell a mom that there's nothing else that we can do, or I don't know why this happened, you did all the right things. I think that's just what keeps me looking for answers.
Yeah, absolutely. It's that personal connection to your patients, and you're a mom yourself. You know what how strongly you want the best for yourself and your children. So absolutely. My last question for you, Rupsha, what and we talked about this throughout the interview already, kind of the big picture, but what is your really big ambitious science goal with this, with aspirin and with preeclampsia and preterm birth and platelet turnover and microRNAs? What's the big thing that you're like, I need to get that? I'm just and I'm not talking about kind of personal career ambition here. I'm talking about, your passion here. What is that passionate thing that you are striving for every day? The big scientific goal.
Yeah, well, I think so. I, preeclampsia and preterm birth have been historically and continue to be leading causes of both maternal morbidity and mortality and infant morbidity and mortality. It affects everyone. And there's medications that we're using, like aspirin, to help prevent preeclampsia and preterm birth, to promote the healthy development of the placenta. But what we're doing is not enough. The rates of preterm birth in the United States have, been persistently at around 10% for a number of years now. And I think part of the reason that what we're doing isn't enough, there's a lot of things to talk about, but I think part of the reason is that we don't have a good understanding of these disease processes, or of what the medications we're using, what they're actually doing to prevent these disease processes. And so one of my personal goals is to better understand the medications that we're using in pregnancy, how pregnancy changes, how these medications are processed, how they work in the body. I think for a long time, like I said, pregnancy as a condition has been ignored as far as its impact on medications and how they're used in pregnancy. And pregnancy changes enormously the way a number of medications work. And on top of that, the individual factors that may impact how medications work. And so I think for too long, we've been using medications in pregnancy the same way we use them in non-pregnant adults. And I think that's shortchanging our pregnant moms and helping them do the best they can to have a healthy pregnancy and to be healthy themselves. So I think, my personal goal is to better understand both existing medications in pregnancy and to use our research to help develop new tools to attack these problems, because we need to do a better job of addressing preeclampsia and preterm birth in the United States and internationally.
You said it. Rupsa, thank you so much. It's been so enlightening. You've been a pleasure. You explained everything so well, and you're doing really, really important work. That this question of higher dosing for high risk pregnant patients and aspirin dosing. You're an integral part of that. An integral part of that question and that solution. So thank you for spearheading this effort, and thank you for coming on the show. Come back anytime. You're due back in 1 year, you said, to tell me about
happy to be
the
here
results.
and happy to come back.
Thanks, Rupsa.
Take care.